relatively shorter talk today, um, but basically want to go over with you guys at least the idea of diagnosis and sharing that diagnosis. I think we'll talk a little bit about, there are things that we can do to try to increase our confidence in the diagnosis. But I think first having that discussion is really important. So the objectives here, we'll go over a few things as far as what, the importance of it, but also just, how not to do it, right? And then how to improve that process, because I think there are some pitfalls sometimes with this. Ultimately, in many respects, a dementia diagnosis, I mean, it goes back to, as far as our medical training, delivering bad news, right? This is not, a diagnosis to take lightly, but there are some tips that we can do to help improve this. And then the real key is also what comes after a diagnosis. So if it is all, you know, there's nothing left to do, or if the diagnosis does not come because there's thought that there is nothing to do after a diagnosis, then that's part of the problem, right? So when we think about improving our diagnosis, one thing is being more aware of the criteria. So, like for example, Lewy body disease is the second most common cause of dementia. Patients will see an average of 3 to 5 different physicians before getting a proper diagnosis, and part of that is a lack of recognition of this second most common cause of dementia. So there's all sorts of diagnostic criteria out there. DLB's diagnostic criteria was updated in 2017. I'm sure we'll get an update again shortly, but this is still pretty accurate. There's pretty good criteria. Behavioral variant frontotemporal dementia, there's been criteria since 2011. Certainly the most common thing we see is Alzheimer's disease. We've given talks in the past about how we diagnose mild cognitive impairment. However, knowing that there's many different causes, right? But can you diagnose mild cognitive impairment due to early Alzheimer's? Yes, you can, with certain criteria, and probably biomarkers is where the field's going to be going for that type of diagnosis. But it's important, and part of this, the importance is of recognizing things early, right? So it allows us to potentially evaluate for any reversible causes that could be accelerating someone's disease. So those can include things like sleep apnea or medications, or potentially other, depression, anxiety that could be accelerating cognitive changes. It helps from the family's perspective, right? In many cases, family members have been noticing things for years. They've been trying to tell their loved one, hey, we should go see a doctor about this. But in many cases, either the patient is not willing to, or even if they bring it up with their primary care provider, it's just kind of called normal aging, or there's no kind of further investigation into it. This helps validate their concerns and kind of helps explain why they're seeing these changes. It also opens the door for different services. This is especially important for folks with young onset disease, because these are the patients that are still working. And for many, for most of our young onset Alzheimer's cases and even frontotemporal cases, they go like an average of 4.5 years before they receive a diagnosis. And so sometimes they're trying to land 5 different jobs and keep getting fired from jobs and uncertain why. And they're not receiving the appropriate social services for someone that has cognitive impairment. Treatment-wise, some of these medications can really help with memory. We talked about that in the previous talk. And the oversight with this, with these chronic diseases and medication management of it is really important. So, we see lots of cases where patients that all of a sudden their hemoglobin A1C comes back at their primary care doc visit as 9 or 10 or even greater than that. And then it's like, well, why is that happening? Well, they haven't been managing their medicines appropriately because they have cognitive impairment that has gone unrecognized, right? So these are really important for their overall health too. And then it also increases opportunities for research, especially when we've lost less brain cells, right? I mean, it's so important to get patients involved in research early, and that's part of what we're advocating for. If we're just recognizing at late stages of dementia, there's only so much we can do with research angles on that. And then this also helps patients and families really plan for the future. So patients are at high risk of injuries, driving related, financial injury, personal relationship injury, right? Not just physical and medical. And taking those proactive approaches to transitions is important because, if all we're doing is recognizing points of crisis, I can guarantee there's not much we can do with medications at points of crisis. We've really got to be more proactive with our approaches. The importance of a disclosure. So 90% of Americans want to know if their memory symptoms are due to Alzheimer's disease. Patients and caregivers, again, just get that sort of, we have an enemy, a name to the enemy, right? We have an idea of why these things are happening. There's a sense of closure there, right? And according to the Alzheimer's Association, less than 50% of patients are told they have dementia by their provider. They may be on donepezil or memantine or some of these medicines we use for dementia, but they were never necessarily told that they were being given those medicines for. That's not a unique problem to the United States. It's even worse in other places. Some people have labeled this as paternalistic, right? Oh, we're just protecting the patient by not telling them. But again, most people want to know. Part of the issue is, there's just not enough of us cognitive neurologists. There's not even enough neurologists. If you look at the state of Kansas, we're a desert of neurologists. So, in many cases, primary care providers are the front line here. So this is part of the problem. And we've got more and more people that are getting dementia because we have a rapidly accelerating, group of 70 and 80-year-olds that are far exceeding our capacity. Part of this is partly why we do these things of education and things. Almost 40% of PCPs say they're never, or at least sometimes, uncomfortable making the diagnosis. And then Medicare's reimbursement plans really put a challenge there too, because these things are things that you can't have a 5-minute discussion on Alzheimer's disease. You need time, and so the medical system doesn't incentivize this in many ways. There are chronic care management models that started with the 2014 Advanced Care Acts, and so that can alleviate some of these issues. So there are billing mechanisms out there to try to help bill for time. So be aware of those. And then as far as the family and caregiver issues, right, a lot of this, there's a lot of phone calls that come from family members due to changes in symptoms. There's missed appointments. Oftentimes patients are not remembering appointments, but getting family involved can help with that, right? But this is a system-wide issue for sure. So as far as like how not to disclose, I think probably one of the bigger ones I see and hear about from family or from other patients is not planning enough time. So this is a life-altering diagnosis in many ways, right? But also not involving family members. So if you're dealing with someone, especially if with memory problems, the majority of them are going to be unable to explain their diagnosis shortly after that disclosure. And involving family members is important. You're still delivering the diagnosis to the patient, but with family present. Leading with the diagnosis. Now, most primary care providers have some sort of long-term relationship with their patients. That's different in my world where I'm often meeting patients for the very first time, but you're still trying to establish rapport instead of just coming out and saying, I think you have Alzheimer's, right? So that's, sort of delivering bad news one-on-one or 101, not to do that. Being definitive without evidence. So when I'm diagnosed, someone, even when I'm meeting them for the first time, I'm walking through all the pieces of information. Hey, these are the things we've noticed changing and families have noticed changing over the last, 4 or 5 years. This is what your cognitive testing looks like. These are actually scores that are outside the abnormal range of aging. This is what your brain scan looks like, right? These are complex neurologic puzzles. So having more pieces of evidence can be helpful. And obviously, if there's any sort of uncertainty in the diagnosis, that's where we either need to seek expert opinions or we need to require more tests to help with that. So most of these discussions are going to take 30 minutes. There's going to be lots of questions. And many of these questions you won't be able to answer, and I can't even answer, right? What do the next 5 years looks like? We get all sorts of questions. Why is this part of the brain not functioning like it should? But it's important to at least that the family and is heard, right, with these questions. And then connecting them with resources afterwards is important. Um, but the point of involving family members is really key because one, they're going to have to start playing roles in supervision and support for this patient, right? Chronic disease management, medication management, financial oversight, sometimes driving discussions, right? All these things become important in a progressive neurologic disease. And this patient is going to need a team, right? That includes you as the provider, your social work team, right? The physical therapy team, maybe a cognitive specialist as well, but the family is going to be extremely important. So involving them when possible is really important. Before you tell them the diagnosis, I mean, I often like to ask and just to clarify, because oftentimes you'll get patients that have a wide range of recognition of what the symptoms are. They may be in full denial. They may have no insight into their symptoms. That happens. And this can be very tricky to deal with, but at least knowing where they're coming from is important. So then you can kind of navigate that appropriately. So you want to reassure, obviously, that you've heard all their concerns, and then basically going through those kind of pieces of information. I will tell you that in my clinic, I mean, neuroimaging can really help because a picture is worth 1,000 words in many cases, right? So like whenever I am seeing patients, I'm utilizing these brain scan images, and oftentimes this gives a very clear explanation to patients of why their loved one is struggling. So like here's a glucose PET scan of the brain, which I've shown you guys some of these in prior talks, where gray is normal here and the more abnormal is where it's kind of becoming more colorful along this bar. This part of the brain is especially important for word finding and word knowledge. And that was the primary symptom they were having. It's very clear why their loved one is having these symptoms. We see it right here, right? And I can tell them with great confidence that this is what the diagnosis is. You have semantic variant primary progressive aphasia in this specific example. So when these puzzle pieces align, it can be very helpful for family to understand. Biomarkers are going to be helpful. So this new test, this p-tau 217, I mean, this is very promising. I always say the caveat of you can't just do a blood test and diagnose someone, but it can be very helpful in the correct context of, okay, they've got memory issues, it's been progressive, they have abnormal cognitive testing, maybe their MRI, at least looks pretty normal, maybe some subtle changes. Oh, and then we get this positive blood test. That can be very helpful. You always need to make sure you're ruling out all the other things. You don't want to miss sleep apnea as a major cause or miss that they're on 3 different anticholinergic medications. But these types of things will be helpful. And particularly from a practicality standpoint, the blood test is going to be helpful. So you want to set the stage. You're obviously wanting to acknowledge the changes, especially that family have noticed. Some of our providers do split family and patient, especially when they're gathering information. Some family members are not comfortable talking about details of symptoms they've seen in front of the patient. I try to do it all with everyone in the room, and I will usually say, look, there's no judgment in this room. I just need to know what's going on so I can best help you, right? And most people are okay with opening up in that forum, but there are cases where we do have to actually separate folks. I'll encourage family members to bring a piece of paper or send me a message separately if that's what works better. But we want to acknowledge those changes and demonstrate understanding. We may mirror some of the language, so you may not want to say that you have a problem with your memory, especially if they are saying, I'm noticing some changes, right? You might want to mirror some of that language. You don't want to create points of friction. I already said this, but to re-highlight it, right? No single test will make the diagnosis. And we've gone over these things in previous talks in the past. So when we are delivering that diagnosis, right, we're creating that confidence by building up this process. And if I'm not confident in it, I will say, look, this is what I'm most concerned about, right? But I've got these things in my differential. These are the things we're going to do to try to work that up. Maybe you need a sleep study. Maybe we do need to do biomarker testing for me to feel more confident in the diagnosis. You can utilize possible diagnosis, probable, right? And then, you're going to deliver that diagnosis directly to the patient, but with obviously family ideally in the room with you. And you want to kind of assess their understanding a little bit of the diagnosis, and you want to be responding empathetically to that as well. So as far as, another major pitfall in, at least you could really argue, most medical systems in the world, certainly in the United States, is what happens after a diagnosis. So even in the specialty field of cognitive neurology, this is a major shortcoming. So a lot of times once people actually do get the diagnosis, then they're often unclear where to turn next, right? And so a lot of that is this sort of lack of resources, or at least lack of knowing where to find the resources, lack of assistance with that, and then really unclear communications of what are the next steps, what can I be doing lifestyle-wise, what should I be doing medication-wise, and the one that really haunts me and that we really struggle with is these sort of lack of predictors for long-term outcomes. Even when we diagnose someone with mild cognitive impairment, um, it's some people will convert to dementia in 1 year, some in 10 years. And we don't have a great test right now to say you're going to be in this 10-year group versus the 1-year group. It requires kind of longitudinal follow-up over time for us to kind of get a great sense of which group they may be in. So as far as where do we go from here, after a diagnosis, it's essentially, one, the earlier we can make that diagnosis, the more we can focus on that quality of life, well-being. The more likely you're going to be able to get somebody an exercise program when they're at early stages than when they're at later stages, right? Apathy being one of those main problems in later stages. And then if you've got a patient that's asking you, well, should we take that trip to Europe now, or can I wait a year? I mean, there's no black or white answer to that, but you probably should be starting things earlier on the list, right? When symptoms are more mild. And that's when these lifestyle interventions have the biggest impact to try to slow things down. This is also where the research studies are going to show the most promise, the earlier in the disease that we can diagnose someone, right? And like I said, this is a life-altering diagnosis, but it's also a progressive condition, right? It's not okay, here's your diagnosis, you know, and we won't ever set a follow-up up. I mean, there's going to be questions that they're going to think about when they get home, right? They're going to need some sort of follow-up with a social worker, or at least a nurse, or some sort of member of your team that can help answer some questions that they think of after the visit. And then planning for the future, right, is really how do we best support this patient and their family, and being proactive here is important. So, we want to try to go after it. We had a whole talk on the purpose of prescribing memory medicines, right? But also we want to reduce all those contributing factors and rule out contributing factors like sleep apnea or anxiety, depression. Sometimes these show up more as irritability or decrease in their hobbies. Lifestyle does make a difference, especially exercise. So the more you can motivate someone to take that step. I always have the saying when I'm talking with patients, the heaviest weight in the gym is the door to get in, right? So it requires multiple providers with the same narrative of this is really important for your health and really important for your brain health. And I wish we were at a point where we could prescribe exercise. We've got studies ongoing that hopefully that is the future, where we can prove it enough that we could prescribe it as a treatment. But right now we can only really strongly recommend it. It is my patients that are doing all of these things, treating their sleep apnea, treating their depression, that are exercising regularly, that are having a good healthy diet. Those are the folks that progress slower, right? And so really highlighting that is important. And then offering caregiver support. This is not just a diagnosis for the patient, it's a diagnosis for the family, right? So they're going to need support through this journey as well. We have this lifestyle enrichment for Alzheimer's prevention program, the LEAP program. So there's a free online course. We kind of have a brain health boot camp that kind of walks through these 6 pillars of lifestyle things. So highly recommend patients and families getting involved with that. What's the purpose of all this? Do these things reduce the amyloid and tau changes? Does it bring the brain volume that we've lost back? It does not. We don't have any evidence actually that it does those things. But what it does do is it helps increase one's cognitive reserve and try to help preserve functionality and independence, right? So if we're able to really support someone's cognitive reserve with all these lifestyle things, then hopefully we can slow things down. Because it is very true, if you put someone in a isolated environment, they just watch TV all day, they're sedentary, they have a bad diet, they have poor sleep, like I think we all know what's going to happen with their cognition in that scenario. The opposite can occur when we really focus on these lifestyle things. And I use the analogy of, like, even if you have these amyloid and these amyloid plaques and tau tangles developing in the brain, do you have viable routes around that traffic? That's what we're trying to build with this cognitive reserve. You're basically helping support synapses between neurons. Our cognitive care network team, so that's our group of social workers, and the main point of getting them involved early is at a point of diagnosis. One, for further disease information and for being proactive, but we want to change the model of just intervening with a social worker at a point of crisis. The most common story, right, is patients not caring for their hypertension or their diabetes. They have health complications. Maybe it's a fall, maybe it's something else. They get admitted to the hospital and it's found out, oh, they're not able to care for themselves anymore. Now we're waiting for placement. Then we get a social worker involved, and then we're dealing with basically a placement issue. And this can be the spiral down that we see of patients. And if we were more proactive about that, right, getting family involved early, getting resources appropriately lined up. In some patients, it might make sense to move into independent or assisted living early rather and avoiding that hospitalization, right? Where there's medication management options in place. It is these sort of repeated hospitalizations and confusion and delirium episodes that really does seem to accelerate the disease process. So I think actually I should edit this. I think we're closer over 100 PCPs that we're working with throughout the state. So it's not, our social work team is limited too. So we can't, if there's 50,000 patients with dementia across the state of Kansas, we can't see all of them, obviously. But it's helping increase the knowledge of social workers throughout the state. So giving these sorts of, education sessions and how do we best support families, that's what we're really looking for. We're looking for partnership because it's going to take all of us, not just a small memory clinic. So this is the idea of shifting that point of care, and the goal is being to provide this collaborative practice environment, empowering, support, and hopefully extending function, right? So, when people say there's no reason to get a diagnosis, the whole goal is to really try to extend one's independence and quality of life, and there are things that can be done to do that. And we really need to shift this crisis-driven model. So similar dementia support systems have shown benefits across multiple domains, not just for the patient, but for the family and for the overall healthcare system. So it's something that would be beneficial from a long-term financial standpoint too for the healthcare system. So there's multiple reasons why these models need to be pursued. When we have surveyed families as far as so 231 different clinic surveys plus the community. So when our social work team, our cognitive care network team gets involved, has this been helpful to you, right? Almost everyone agrees with this across the clinic and community. Part of this is disease education, understanding the disease, understanding disease staging. So our cognitive care network team has a lot of resources that are partnered with, say, the Alzheimer's Association and other resources to help with those disease education questions, extremely beneficial. Managing the disease-related challenges, there's all sorts of behavioral symptoms that occur, but if we can be expecting those and have different strategies for dealing with them, then that can be extremely beneficial for families. And so overall, it's been a very beneficial program that we just need to expand that across the state and ultimately to even larger regions than the state, right? So hopefully that was clear as far as some of those tips for disclosure. I think the more evidence we have behind the diagnosis, the better. You don't always need biomarkers, right? But obviously when those become more available, that will be even more beneficial in feeling confident in the diagnosis. And then, we have a lot of work to do of what happens after a diagnosis. So hopefully that highlights some of those things for you guys. I'm gonna stop sharing this. Let me just check the chat real quick. Looks like it's all about CE codes. So